far you have come on your own, but never alone. Through the rain and through the shine, here's your moment, it's your time. You stood tall and now you see, standing in your destiny. 100 women growing strong. 100 women where you belong. You stood tall and now you see, you have reached your destiny. Woman, woman.
As people of African descent, we offer this land recognition in solidarity with the indigenous peoples of Turtle Island in the efforts and deliberate intentions toward decolonization. As people of African descent, we acknowledge the land of Turtle Island that sustains us, express deep gratitude to its indigenous peoples, and pledge to honor our dignity and divinity that ultimately connects us all. By Kay Johnson. Welcome to 100 ABC Fireside Chats. 100 Accomplished Black Canadian Women is a bold project initiated by co-authors and co-founders, the Honorable Dr. Jean Augustine, Dr. Denise O'Neill Green, and Donna Jones Simmons. Our mission is to celebrate and archive the professional accomplishments of trailblazing Black women from all across Canada. The goal is to create an ever-expanding database available for current and future generations via print media, public and private libraries, as well as our website, which is www.100abcwomen.ca. In addition to our fireside chats on topics that matter to our communities, such as education, healthcare, entertainment, creative arts, trade union, and so much more, we offer biennial book launching galas and biannual symposiums. The co-authors and co-founders would like to take this opportunity to thank each of you for attending today's fireside chat. We know that you will find these sessions educational and inspirational. So sit back, relax, and hear from our brilliant and talented honorees.
Hello, everyone, and welcome to another Sunday, a special time where we come together to center, celebrate, and reflect on the experiences of Black people, Black women, and healthcare. It's truly a gift to share this space with all of you. My name is Nancy Sims. I work as a principal consultant for Nancy Sims and Associates, and I am the moderator for this session. I hope you're doing well and finding moments of peace in your day. If you're anything like me, you may have gotten an early start on dinner, so you can now unwind and enjoy a little well-deserved me time. These small acts of care matter. And today, we are going to be focusing on care, compassion, and community connection. I'm so very glad you're here. I want to extend a heartfelt thank you to Andy Weatherburn for taking care of all our technology needs and ensuring that everything runs smoothly behind the scenes. I also want to offer deep gratitude to Sister Donna Jones Simmons for your unwavering dedication and vision, your relentless commitment to creating and sustaining a platform where Black women can take up space, speak freely, and own their voices in both, which is both powerful and necessary. Because of you, Donna, this space exists, and because of that, so many of us are able to feel seen, heard, and supported. These sessions should not be taken for granted. They offer us a chance to pause, to reflect, and to be nourished in ways that truly feed our souls. I encourage you to prioritize this time as best as you can. And please don't keep it a secret. Tell a friend, a co-worker, your sister, your mother, and most definitely your daughters. The more we gather, the stronger our community becomes. Today's fireside chat is titled Examining Healthcare Equity, Culturally Responsive Care Models, and Community Health Innovation, with expert perspectives on policy, practices, and living experiences. This is an especially meaningful and timely conversation as we continue to explore not only the gaps within our healthcare systems, but also the opportunities to reimagine care in ways that are equitable, inclusive, and responsive to the needs of Black communities, particularly Black women. We're truly gifted today with three remarkable women who bring a wealth of knowledge, insight, and living experience. Each of them has a deep understanding of the Canadian healthcare system, and it holds for Black women. Their voices reflect a powerful intersection of expertise in policy, frontline practice, and community engagement. Thank you again for being here. Before we get started, I wanted to take a few minutes of your time to till the soil. That is, to get us all ready for the questions I'll be asking each of the panelists and the rich knowledge embedded in the important dialogue that the panelists will share with us. One that not only examines where we are, but also inspires us to think about where we can go and how we can collectively contribute to building a more just and responsive healthcare system for Black people. One of my earliest learning in the equity field was that when we provide services, effective and efficient services to the most marginalized, everyone benefits. And I know this is important to us as a people because we've never ever only wanted the best for strictly for ourselves. We have always considered the whole. So when our healthcare is centered and responded to with knowledge, care, and compassion, everybody else in Canada will benefit. There is a truth, one that has been echoed time and time again, that systemic discrimination remains embedded across Canada. It operates at a structural level, shaping outcomes and experiences within our educational systems, our justice systems, our financial systems, employment systems, and of course, our healthcare system. Today, we're turning our attention specifically to healthcare. While there is still a troubling lack, a real paucity of comprehensive research examining how Black people are treated within the Canadian healthcare sector, we do have some data. And even in the limitations, that data tells us a revealing story. It points to the disparities in access, differences in quality of care, and patterns of bias that continue to affect health outcomes for Black communities. So, with that in mind, I'd like to take a moment to share a few key insights and pieces of information, points that help ground our conversation today in both evidence and living reality. In 2023, researchers Kapisetaki and Wing Chan highlighted a critical fact. Black Canadians continue to experience poorer quality healthcare, worse health outcomes, and a disproportionate higher burden of health inequities. Much of this, they argue, is rooted in the unequal distribution of the social determinants of health. That is, the conditions in which people are born, grow, live, work, and age. Now, as an educator, what makes this finding striking for me is that Black people between the ages of 25 and 54 are actually more likely to hold a bachelor's degree or higher, approximately 42% more likely than their white or non-Indigenous counterparts. This is a powerful and important point. I want to name this clearly, right from the outset. The disparities we see in healthcare are not due to a lack of education, awareness, or effort on the part of Black individuals. The issue is not about personal shortcomings. It is about systemic barriers, biases, and inequities that persist regardless of education or socioeconomic progress. In other words, even when a Black person is highly educated, informed, and engaged, they're still navigating a system that does not consistently serve them equitably. And that is exactly why conversations like the one we're having today are so necessary. I will place the 14 determinants of health in the chat shortly, and I'm sure the panelists will also address them. I now turn to introduce the woman that you're here to learn from. It is indeed my privilege to introduce Angela J. Carter. Angela is a community-rooted systems change and racial justice strategist who has spent more than 4 decades listening deeply and intentionally to the voices of communities too often unheard. Those voices, particularly from Black, African, and Caribbean communities, revealed patterns of exclusion, gaps in healthcare, and the silent toll of systemic racism. Angela carries these stories into boardrooms, institutions, and government offices, insisting that systems must respond with services and resources that are wrapped in dignity and accountability. Next, a woman who you would have heard from just over a month ago on a similar topic, Alitia Kador. Alitia is an author, psychotherapist, clinical supervisor, and wellness visionary who organized the first multidisciplinary wellness hub for entrepreneurs and practitioners. As the founder of Minds Like Consulting and Community Practice, Inc., Elitia creates healing spaces that center emotional regulation, self-mastery, and community empowerment. Her work bridges mental health, entrepreneurship, and leadership, ensuring that Black and Afro-Indigenous communities thrive with intention and strength. Next is Carrion Fenn. Carrion is an award-winning healthcare advocate, community leader, and media host dedicated to advancing mental health, youth empowerment, equitable access to care, and advocacy for optimal patient health and high quality healthcare systems. Karen is the founder, president, and CEO of the Karen Fan Foundation and the host of Health 180 with Karen Fan on Rogers TV Durham. There, she leads important conversations on health, wellness, and systemic change. Karen previously served as a board trustee with Lake Ridge Health, where she was chair and past vice chair of the board quality committee and committee board chair of the Ajax Pickering Hospital Community Panel, supporting governance across 5 hospitals, Pinewood Center for Addictions, long-term care, and Durham Mental Health Services. Karen was the first Black woman to run for mayor of the town of Ajax. Rooted in lived experience, Karen continues to champion inclusive, community-driven solutions that empower individuals and drive systemic change. Please join me in welcoming Angela, Alethea, and Karen. Thank you. So we're going to have 3 rounds of questioning. I'm now going to head into round 1. And the first question goes to Angela Carter. How can healthcare systems move beyond recognizing inequities to actively building culturally responsive models of care that improve trust, access, and outcomes for communities that have historically been underserved?
Thank you, Nancy, and good afternoon, everyone. It's an honor to be among such brilliant Black women here today. My work is dedicated to ensuring that Black health isn't just a data point in an equity report, but a priority in policy and a standard in practice. Today, I want to talk about how we move from surviving the system to thriving through systems that we help design. So recognizing inequities is an important first step, but recognition alone does not change outcomes. Moving forward requires a shift in how healthcare systems understand both patients and communities. Culturally responsive care begins with acknowledging that health is shaped not only by biology, but also by lived realities, things like housing, income, immigration experiences, racism, and historical relationships within institutions. What are called social and structural determinants of health that Nancy mentioned. When these realities are not understood, care can unintentionally miss the mark. One important approach is cultural humility. It asks that providers to move from assuming expertise about a patient's cultural competency, to entering the encounter with curiosity and respect, recognizing that patients bring knowledge about their own lives and strengths into the interaction. This helps to narrow the power imbalance between patient and the provider and start to build trust that is such a fundamental aspect of healthcare. But systems alone need to go beyond individual interactions. We need stronger partnerships between healthcare and institutions and community organizations that already hold trust with communities. These organizations often understand the barriers people face long before those barriers show up in the hospital and in hospital data. This was evident during the COVID-19 pandemic when Black organizations like Roots Community Services stepped up to educate, dispel myths, and bring the communities together to hear from doctors and other medical practitioners that look like them. Roots CS worked alongside the region of Peel, Ontario Health, and other community agencies to reduce the impact of the pandemic on our communities. As we know, at that time, Peel region, where we are from, I know many people are from other areas, had one of the highest rates of the pandemic here. And we together pushing the systems, pushing the Ontario Health, pushing the ministry and the region, said, work with us. We know our community. We can work with them. We can make a change, and we did. So ultimately, cultural responsive care is about designing systems where people feel seen, heard, and respected. When that happens, trust grows, and trust is one of the most important foundations for improving health outcomes. You can say that trust is a form of healthcare infrastructure. I'll stop there because I have others and I want to hear my other colleagues, and then we have some more to say in the other rounds. Thank you.
Thank you so very much, Angela. That was quite fulsome, and I really like the whole thought about cultural humility. Something I will personally look into further. And so the next question goes to Karian. How can healthcare systems move beyond performative commitments to equity and meaningfully integrate lived experiences, particularly from Black and marginalized communities, into policy design and service delivery?
Thank you. I'm honored to be here today, and glad to be joining among amazing women. I think in terms of addressing this, it's impacted me a little bit more than I thought. When you're on the inside and when you're in leadership and when you've had access to do meaningful change and knowing the system, it hits a little bit different once you know certain things and are aware of how systems work. Equitable healthcare starts with understanding that one size does not fit all. There are many youth, marginalized community that faces systemic barriers, whether it's language, cultural differences, or lack of access to local services. Innovative strategies could include mobile health units, telehealth platform, hearing directly from community who are receiving the services. And this will help underserved communities in training of providers in culturally sensitive areas. Policy-wise, we need mandates for equity audits, including service design and accountability measures that ensures that funding and resources follow the communities with the greatest needs. Equity isn't just principle, it must be measured, actionable, and sustained. And I say this too as someone who, I was responsible for quality care for 2 years during the global pandemic and responsible for taking the hospital through the pandemic. I speak for myself, not for any organization, but as someone who uses services, understand the importance of having equitable access to care. I think it's going to come with a strong allyship and a strong support from that allyship and working with our community, the ability to have meaningful change in a way that access is fair for all. It's going to take more than conversations, more than showing up at events and buying tables or buying space or sponsoring events. I think one of the things that's impacting our community from moving forward, and the survey, I know I'm tired of the surveys, but it does not work in that term. I think we need to make sure that even if when we have service workers from our community, our marginalized community, we need to do exit strategies in regards to why they are leaving. They are, from a healthcare perspective of the individual providing service, to the patient receiving service on both ends. When you're from the marginalized group, it's not working. And I think it's not working because there are meaningful change that are required, but it's going to take a certain structured leadership to make it work. It's doable. But we're also finding that, individuals from the identified groups are preventing that progress. So we need to do work and actionable work from a place of, regardless if you're paying me the big bucks or regardless if you're giving me the money, I work from a standard where, even if you're funding me to do a project, you don't take my voice. But I think it's doable. I think we can make a change, but we need to change how things are being done now. And it starts from the top of meaningful change and not window dressing.
Thank you. Thank you so very much. I really like the idea that you actually critiqued allyship. And that's so important because quite often people say, they're an ally, but it's not accompanied with meaningful action. So thank you for that.
You're welcome.
And stressing the one size doesn't fit all, which continues to be one of the policy barriers to effective care. Thank you, Karen.
You're welcome.
So I'm going to move right on here. And this final question for round one is directed to Alethea, and it flows nicely from Karen's response. So, Alethea, despite ongoing efforts, many communities still face barriers to accessing quality health care. What innovative strategies or policies can be implemented to ensure equitable, culturally responsive care for all, especially for youth and marginalized groups? Thank you.
Thank you for that question. And I want to say good afternoon to everyone that's out there listening. And I'm so happy to be here with these distinguished women in health and innovation. And when I think about innovation in healthcare, when it comes to mental health, I don't just think about technology or new systems. I think about returning to what has always helped us as a community: connection, culture, and also the same thing that Angela's saying, cultural humility, which is the ability to understand our needs and to address those barriers, because it's not only about access, it's about being seen, like Carrie-Anne said. And when we're misunderstood and when we don't feel safe in the system, things happen. And there is documented evidence of a history of us being denied access to care or given care that was not sufficient. So to me, innovation goes beyond services. It has to rebuild our trust. And when I have worked in these types of settings that manage and support people that look like me, I find that when I'm able to create a space of belonging and having things that they can relate to in terms of community-based wellness or culturally responsive care, which means understanding the history of African peoples and what we used to heal ourselves when we were not living in these harsh North American conditions. And what I found was healing doesn't happen in a clinical setting. For us, it happens in community when we build relationships with one another and we're able to share our experiences. And I find that when we're able to do this and we're able to truly be ourselves, that's where healing occurs, in our safe spaces.
Thank you. Thank you so very much for that, Alethea. The whole idea that healing does not happen in a vacuum is something I think we just need to remember and live on a daily basis. But I want to particularly thank you for voicing the importance of knowing the history of African people in order to work effectively with them and in order to foster feelings of belonging, particularly, as you said, prior to us being in these conditions, because we weren't born in these conditions. We were stolen and brought here and have survived very, very well. And for some of us, we've even thrived and flourished. So thank you so much. Before we move on to round two, I'd like to pause briefly and invite any of our panelists to share any additional thoughts or reflections. If anyone has a final comment or would like to build on what either or any one of you have already discussed, now would be a great time to do that.
Yes, I would like to just comment on a comment that Carrion said about even if you're funding me, you don't take my voice. And that is something that is so important and something that we have to fight against all the time because, within our communities, I'm speaking about the Black African Caribbean communities now, we don't have a lot of resources ourselves that go in and we rely on funding from primarily government and others. And obviously, we think that when we are funded, we have to do what the funder says. And I think that is something we need to stop doing. We have the expertise. We need to be able to say to them is, thank you for the funding. These are the results you're looking for, and we know the best way of getting those results. And I think we need to keep saying that and pushing back and just numbers are not the only thing. We not just quantity, we believe in quality, and we need to say that. So, if Alethea and Karen can expand on that, that's great.
Yes, I'm going to thank you. I'm going to touch on that because I've been working with Mayor Kevin Ash for about 3 years now. And one of the things that I said to people, and one of the reasons why I've been successful at the project, which also looks at how systemic barriers impact the Black community. It goes from emotional impact to physical impact. More people are going to the hospital for care. More people are going to see a family doctor. More people are being diagnosed. But when I look at even having this conversation with you today, when I look at how I've been working with him for the past 3 years and being able to be funded by the Pickering Mayor's Gala private funders and still have maintained my voice. There's nothing like it is so crucial for the next generation of our community members that are coming up, the kids that I mentor. They're relying on us. And we just can't afford to, even though we need it, but I think we have to make a stand and we have to make it clear that because you're funding us, so that I'm clear, I did not have to establish that. So I never had Mayor Ash try to micromanage me or tell me what to do. He just makes sure that I have the resources that I need and I just run with it and do what I do best. And having that freedom to be able to make the change or bring about the change or create the project or implement the project without interference is so key. And that's what it's going to take for us to be able to have a system that where we're going to be treated fairly, because it's not easy. And from experience, it is not easy, but we need to be able to maintain that voice. And we have the upper hand, even though someone is funding you, they need our talent. They need our experience. They need our leadership, right? But I think we have to make it clear in terms of that. And I think moving forward, I think we'll be able to make and have meaningful change.
Thank you for that, Carrie. And I think you touched on something that resonates deeply with me as an independent consultant and being very much aware that you can't pay for my voice. And Takes a lot of courage, easier said than done, right? Sometimes you have to walk away from those contracts um, because there has to be some integrity. I often say to people, when I get home, I have to look in the face of my child.
Mhm.
Have I done him right for
Mm.
that day? So, particularly for those of us who are mothers, it is not an easy road.
Mhm.
So moving on to round two, I'm going to start with Angela. And Angela, thank you for that question. That was great because Karen was able to take us a little deeper um, into the discussion. What role can community-led innovation play in shaping the future of healthcare access? And how can policy and institutions better support community organizations that are already developing effective solutions?
Thank you. When we talk about healthcare innovation, we often look towards the future, toward new tech or data. But true innovation in our community often means looking at the humanity that the current system overlooks. Many of the most promising innovations in healthcare access are actually emerging from communities themselves. Community organizations often see challenges before systems do. And when we say systems, we mean the large institutions that operate within outdated systems that are oppressive and racist. The community organizations understand the cultural context, the practical barriers people face in navigating healthcare, and the kinds of support that truly make a difference. They understand the humanity of healthcare. Across the healthcare landscape, there is increasing discussion about integrating services. And in many cases, that has meant co-locating providers in the same space. And while that can improve really the coordination, it does not always change the underlying experience for patients. And what we are beginning to explore in some community-led initiatives goes much further. For example, I'm not sure if you all have heard about this, but the vision for the Black Health and Social Services Hub in Peel region that we are developing doesn't simply place services side by side. It moves beyond co-locating. We are creating a truly integrated model where healthcare, mental health and addiction supports, and social services operate as part of one seamless ecosystem around the person and their families. So while we might have different partners of coming together, it is not co-location. They're coming together and providing a seamless integrated care for someone from the Black African and Caribbean communities primarily, when they walk in, they can access the services from within any of those streams. So this kind of approach recognizes that health outcomes are shaped not only in clinics and hospitals, but also through housing stability, food security, mental wellness, and community connection. The Ontario Ministry of Health is watching this model that we are developing very closely as a potential prototype for how community-rooted integrated care could evolve. So for these kinds of innovations to grow, policy and institutions must see community organizations as essential partners in the healthcare systems, not just service providers on the margins. That means investing adequately in community-led solutions, supporting data and research partnerships, and creating policy environments that allow successful models to scale. It's okay to give the funds to start, but it must have the investment to continue and scale the process. So when communities help design solutions, we move closer to a model of care that is accessible and truly responsive to people's lives. We have to acknowledge and accept that communities are not just recipients of care. They are co-designers of healthcare solutions.
Thank you so much, Angela. I live in Peel, and so I have a question for you, and that is, I really like the idea of the seamless ecosystem and integrated care. I think that's so important. How are people on the ground informed of this? Because I've never heard it.
Oh,
So, how is it being socialized? How is it reaching to those of us who are on the ground, who are probably not visiting the hospitals or physicians regularly?
okay. Well, we're developing still, and actually we are close to really getting our first home. We have been, as I mentioned, there are three partner organizations doing this, and we've been operating from the partners' offices, as well as we going into various areas like the Peel Memorial Hospital and different places. But we are ready soon to launch our space where people can come into that space and have from seeing a doctor to seeing a psychiatrist to seeing a social worker that can help them with housing support, all in that one space. And we also, and someone mentioned the mobile clinic earlier, we also have a mobile clinic that is actually running and going out into the community. So very soon you're going to hear a lot more about it. It was announced earlier. We are working. We have been we've reached over 20,000 community members already. But it's soon going to be very much large scale. It's going to be, when we open up officially, I wish it would be very soon, you will learn a lot more about it and be able to come and see.
Fantastic. Peel is very expansive. I know it covers a wide area. Thank you for that. The next question goes to Karen, and it's on the same vein, Karen, in regards to community-led initiatives often lead the way in addressing gaps in care. How can hospitals, public health systems, and local organizations collaborate to scale these innovations and make healthcare more accessible, responsive, and inclusive?
Communities often innovate where system lack. Hospitals and public health systems can partner with local organizations to scale these initiatives by providing, whether it's funding, technical support, shared infrastructure, um, while respecting community-led approaches. I think in terms of when you have like a systemic structure, the community at large knows what it needs or knows what the system is lacking and can actually give a very good feedback or input in terms of how to provide those services. But often systems don't listen to community. When I was a trustee, being involved in the community, a lot of what I know to bring to the table at the board meetings was through my interaction in the community. And that's a voice that's not at the table. So if I were to sit at the table without being involved in the community as I have been, those voices would not be at the table. Those voices are not a part of the structured systemic conversations that happened. Those voices that I hear in the community allow me to help in how I lead, in how, we were not mandated to the community, but to a different entity where I always thought, okay, wait a second, we should be responsible to the community we serve, not to an entity itself, right? But for myself in how I saw things, I try to see, regardless of doing what's needed, I saw the importance of the community and the need of the community and being able to work with those both. So the co-creation is key, and it's important to amplify what's already worked and remove barriers to access, but collaboration has to be ongoing, data informed, and guided with trust. But the importance of collaboration is needed. You have to hear from the community and you have to hear from service users in order for everything to work.
Thank you so much, Karen. What I'm hearing is, trust is a common theme that I've heard all three of you been addressing. And normally you don't hear that term when you're talking about healthcare. So I'm so happy to hear that it's coming alive and taking root. And so this takes us into Alethea responding to what does it take to move culturally responsive care from an individual practitioner's effort to a sustainable, system-wide model that is resourced, evaluated, and accountable.
Wow, I mean, this is an amazing dynamic question, and I have to kind of unpack it to just address what Carrie Ann and Angela was talking about. And having worked as a practitioner in hospital-based psychiatry for many years, this was something that we wanted to address internally because of the fact that when we had Black youth and Black families that were struggling with mental health issues, one thing was to discharge them into the care of limited resources because at that time we did not have enough Black focused, culturally responsive care for our young people to go to. So that was the gap. And I mean, this was already looked at many years ago with the folks at Black Health Alliance and Pathways to Care. And something that Miss Fente Coleman, which stuck with me for many years, about the access to care for our Black youth and our Black families, and the fact that once they left a culturally diverse setting, because in a hospital, we're all there working in many different forms, from psychiatry to nursing to social work. But we weren't seeing that reflected in the community because we weren't having enough practitioners. And then through the George Floyd movement and the call to action to see more visible therapists working with our community. That's how my practice was created. And I was also wondering, where were the minds that I like? Where are the practitioners that are out there doing the work? And when I did the research, we were there. We were there, but we weren't getting resourced from that navigation piece to say that we can transition our children safely into the care of Black, culturally responsive therapists. That's where the gap was. We weren't getting referrals to support our youth. But now that we have the hub, we have these spaces that are growing. We have the Amani program that has expanded across Ontario to work with our youth, and it's all centered in the root of our African and Canadian diasporic because we've always been here. But unfortunately, we weren't given the opportunity, and we know why, to practice our culturally reflective and responsible care that we know how to do to heal our people. And now this is something that I, along with other therapists in the community from Toronto across the GTA, have committed to in our practice is to not only care for our people, but to hold space for them so that they can address the intergenerational racism and trauma that they have endured over the years of being here. And even though all of us have had lived experience of toiling and being here and supporting each other when we didn't have the resources to do it, now we're expanding. Now we have U of T that has a whole department for Black medical research, and that's expanding to other universities. And now we can definitely have culturally based research And I am such a recipient and proud to have had funding just to look at social prescribing for Black women of a specific age so we can address the stress and the depression and the anxiety that we face by the emotional toil that we've had to carry and that weight of others while we are living here and raising our families and just trying to be as a community. And this is something that I also offer to young people that are in counseling practices, that they have an internship with me. And my internship is only focused for Black and Afro-Indigenous young people to practice with people that look like them. And I wanted to make that commitment to extend through the colleges, and the universities have also committed to ensure that I have Black youth and young Black people practicing in the space to support one another. So this is how we continue with the innovation, is to ensure that we are creating internships, we are creating entrepreneurships for Black youth. And even though you have lived experience, we are saying this is why you need to come on board and support each other, because people want to know, how did you get through it? And they want to know the information from people that look like them.
Thank you. I don't know about you viewers, but this is absolutely food. I think I don't need to eat. This is so rich. Um, yeah. Let me turn to some questions that are in the chat, and any one of you can respond. And so the first one I'm seeing here is from Donna, and it says, many of us have been misdiagnosed
Mm,
and may have gone down a path to nowhere had we not have someone to advocate for us. How can we make this available to our Black community?
mm.
Thank you. Anyone or more can answer that question. That would be great.
I can speak to a couple of things that are happening right now, especially around psychology and increasing the space to see more Black psychologists, more practitioners. So in that aspect, from an educational point of view and that structure, we need to see more people practicing. And also, it would be nice to have, and I'm sure they do have it in some colleges and universities, maybe across Ontario, someone can speak to that, where we would have education for Black mental health. And I know Black Mental Health Canada had developed a trauma manual for practitioners. So, that information is out there. We just need to all have that access to it.
Thank you for that. Anybody else would like to add? Okay. So we're going to move on to round three. And I am going to start round three with a question to Carolyn. Patients' lived experiences often reveal gaps in care that data alone cannot capture. How can healthcare systems more effectively integrate these voices into designing and improving services?
So, data tells us patterns, but lived experiences tell us stories behind those patterns. And to be able to effectively integrate patient voices, we need structured pathway for feedback. And I say that, and I'll give you a quick example. I was at a forum, a hospital forum, and I exerted myself. I'm a chronic patient, and I was in excruciating, intolerable pain at that point because I put my body too much than it can handle. So whenever that happens, I have to go to the hospital emergency room for them to reduce my pain. I was in the ER rather than treated as a patient, which my history would show exactly what needs to be done. I was treated otherwise. I was not given the care that I needed. And often I've heard from nurses who are Black that when a Black person goes into the emergency room, they are not treated as chronic pain patients. They are treated as addicts, and they're not. While I just left an event from a hospital that I've been serving at the top because I was one of the bosses for the president and CEO and the chief of staff for the hospital. I was just representing that role. But when I was in emergency care, I was treated like an addict. And regardless of the fact that it was in my duty as service that my pain went out of control, and here I am in the same hospital, and I was not treated as a human being. I was treated as an addict, which I have never been an addict. And those behaviors happens a lot. Patients are refused medication that are required because they're seen through a lens of being different when they're just human beings. And I say that to say this. So I had a story, and I was the chair for quality care. And after hearing the story, I decided in my meeting, I wanted to make sure that the committee members, including doctors, leadership, they hear from the patient's family. And the patient family wanted to share their experience. But being able to hear patient voice was so crucial. I vetted the story because I knew that the referral came from a lawyer, which was a trustee. So I knew that if there was something to be flagged, he would have flagged it. I didn't flag anything either. But for me, in my leadership role, I felt hearing from patients is crucial. Hearing from the family in regards to what they went through and what their loved one went through was crucial in being able to be effective in quality care. I was checked several times not to do it. When I refused to take it off my agenda, it went back to the board chair. The board chair to come back to me and check me again. And I said, no, I'm going to do it. But the board chair didn't have the authority to change what I needed to do. And that goes to the point of when you need to do the right thing, you need to do the right thing. So I must have been checked about 3 or 4 times to change the structure of what I was trying to implement. Regardless of that, I said, no, it was my decision. I decided to do it, and I did it. The family came to my committee and tell their story, and it was one of the most powerful moments ever. The board chair came back and the president and CEO came back and said to me, Carrie-Ann, I'm so sorry. This was one of the most amazing experience. One person said, I didn't know we didn't have this. And can I have my team reach out to you in terms of how to implement this? And I also heard from the Peterborough Hospital Quality and Governance Chair. They wanted to know how to effectively implement this in the Peterborough Hospital. So I set it up so that in the 3 committees that exist in the hospital I was with, whether it's governance, resource, and quality, patients are able to attend a meeting and share with the community leadership their experience. And through that, even chief of staff, even doctors in different departments, they're hearing from patients. They're hearing how the service their team rendered impacted patients. And that makes a big difference. When they started speaking, it was like everyone started turning on their camera. It was one of the most powerful experiences I ever had as well. It was very empowering. And I say this because hearing patients' voices are so crucial in services that we render in healthcare. And again, when it's coming from the marginalized community, it's a lot more difficult. But those voices are important. Those voices are crucial. And I say this, when we have a role in leadership, we really need to do the right thing, not just there to warm seat, not just there to build resumes and stuff like that, but there for humanity. And the lived experience and patient voices are crucial in healthcare in a way that is equitable and best for our community.
Thank you, Karen. The next question is to Alethea. What would it look like for healthcare systems to truly share power with communities, particularly Black and marginalized groups, in designing, funding, and leading health initiatives rather than positioning them only as participants or recipients? And I think you follow Karian's response quite nicely. Thank you.
Just to reiterate everything that Carrie Ann was talking about, I just was nodding and just clapping along with what she was saying. And that's where it is, just to hear from those voices. Where's the feedback after you have a stay? Where does that information go to? Is there anything that we can do in terms of improving the time that people are spending waiting or, connecting with someone? Does that need to be highlighted or documented somewhere? So those type of stats and feedback really helps. Not only the user's experience, but also the person that's providing the services, so that they can improve in those areas because that care, that front end experience of someone coming in and um, addressing how they feel. They just want to know that they've been heard and that their concern is going to be addressed with the best people that can support them or help them. So it's about centering lived experiences, right? Involving their community voice and then shifting from that word, which I don't like to use as much, treatment, but calling it connection, belonging, bringing them in, and just giving and providing care. And I think it sounds so much better than treatment. Let's look at your treatment plans. It's so harsh. But when we say, hey, let's center you and comfort you and give you a sense of belonging, and we know that you're not well, and addressing that, and here, this is your space where you could get better. It sounds so comforting and inviting and warming. And that's the experience that I've always had when I've been amongst my people. So that's the experience that I want to be able to provide.
Thank you so very much, Alethea. And over to you, Angela. From your perspective, what are the most critical shifts needed in Canadian healthcare policy to ensure that cultural responsive care moves beyond a buzzword and becomes a lived reality for Black women navigating the healthcare system today?
Thank you. And I must say thanks to Alethea and Carrion for such thoughtful and inspiring storytelling this afternoon. So for culturally responsive care to move beyond rhetoric, we need several important shifts in how policy and systems operate. As was said earlier, we need better data and transparency. For many years, Canada did not systematically collect race-based data, which meant inequities were often invisible in policy decisions. Without that data, it becomes difficult to design targeted solutions or measure progress. We can't measure what we don't collect, right? Is one of the things we keep hearing. So responsible collection and use of socio-demographic data allows policymakers and health systems to see where disparities exist and where resources are needed. And I know some people within our communities are concerned about the collection of our data, especially race-based data, because they think it's going to be used negatively against them. And in some cases, some people do. We need to make sure that the data is used responsibly, and we need to understand where that data is being held and how it's governed. So there are moves ahead to do that kind of work. The second, we need to address bias and representation within the healthcare workforce. Many Black women speak about not feeling heard when they seek care. And someone asked a question about Black maternal health. So actually in maternal health, so I have an example here. There are stories of women, especially Black, Indigenous, and racialized women, describing symptoms during pregnancy or after childbirth and feeling that their concerns were minimized or dismissed. And these experiences affect trust in the system and in some cases can delay appropriate care, leading to unnecessary complications and premature death. In Peel region, going back again to the work we are doing, we are just beginning a community assessment on maternal health in Black, African, and Caribbean communities through the Blacy Community Health and Wellness Collaborative. And we talk a lot about collaboration. This is another collaborative that coming together to do this work. And we're doing it precisely because we want to better understand those experiences and ensure that policies and practices are informed by the voices of the women themselves. Addressing this requires not only training in cultural humility, but also greater diversity within the health workforce and strong accountability mechanisms. So a third, policy must recognize that health outcomes are shaped by more than just clinical care. Many of the health challenges that Black people face, especially Black women, are connected to broader social determinants of health, which we touched on at the beginning. Economic stability, housing, stress, caregiving responsibility. And I see Donna has put the list of the 14 social determinants of health in the box. But there's the structural determinants of health. This is racism and those things. So the policies that encourage collaboration between healthcare institutions and trusted community organizations can help address those realities more effectively. So culturally responsive care becomes real when systems move from expecting individuals to adapt to the system to designing systems that recognize and respond to the realities of the people they serve. When that shift happens, trust grows. And as I stated previously, trust is one of the most powerful foundations of improving health outcomes. We know that the systems that we operate under were built and developed centuries ago to keep Black people as slaves, to take the land away from Indigenous people, and to keep racialized people under-recognized. And if we do not change those systems, not keep building on them, we have to change those systems, the foundations of those systems, for us to realize equity, not just equality, but equity in the healthcare systems and for all of us to thrive. Thanks.
Thank you. I wonder if we can just take a moment and pause. This has been an incredibly powerful and thought-provoking discussion. The insights shared by our panelists have been both impactful and deeply moving. I often pose a question to my students that I call the so what factor, and I'd like to extend that same question to all of you who are joining us today. As you return to your Sunday routines, I invite you to sit with what you've heard and reflect. So what does this mean for me, for the community, and for the systems you engage with?
Nancy, there's a question here in the Q&A, which I like to just respond to before we go into what you say.
Yes.
It's from Tanya asking, as this is Women's History Month, what some places, hubs that we can access, especially during menopause? This is a hot topic nationally, but again, it's being pushed out from a white-centered lens. I'm not sure where Tanya is from, but we have been, through the hub, since last year, been running a number of series on menopause from the Black perspective. We have Black doctors that come in to speak about menopause as it affects the Black community. If they want to connect with me afterwards, I could make sure I get their names on the list for these sessions when they come out again, so that the person can get connected.
And so that's in Peel. Anything out in Durham, Karen?
Well, listen, it's some of them online, so anyone can connect from
Okay.
anywhere when we have the online sessions.
Okay. Alrighty. So thank you for that. Just to wrap up, one thing we all know for certain is that at some point, each of us will rely on Canada's healthcare system. And so, as I was saying earlier regarding the so what factor, and so emerging from today's conversation lies a deeper understanding of community-led innovation as critical. We've heard how essential it is to move away from top-down, reactive healthcare model, one that was not designed with Black communities in mind, and we have been reminded of that throughout the session, and to move toward a system that is proactively equitable, culturally responsive, and locally grounded. Creating space for residents to identify and address specific unmet needs is invaluable and it is essential, as Karian shared with us. It strengthens access, builds trust, and integrates care with the social supports and compassion that people truly need to thrive and be whole. As a policymaker myself, and as someone frequently called upon to review and revise policies, I leave this conversation even more convinced that institutions must be held accountable for meaningfully embedding the needs of Black communities into their policies and protocols. And once again, that this cannot be symbolic or performative work. It requires a deliberate combination of top-down structural change, community-led monitoring, and clear, data-driven, measurable goals. Policy without guidance and mechanisms for accountability is simply not enough. It risks becoming words on paper without impact. We must also recognize the importance of agency. Taking ownership of our healthcare means advocating for strategies within healthcare organizations that are concrete and actionable. We have to ask the hard and the unpopular questions. We need to inquire about independent racial equity audits, as was mentioned earlier. When was the last time one was done, if ever? And we must demand the formalization of partnerships with Black communities and attaching leadership performance directly to their involvement in the communities they serve, coupled with the implementation of anti-racism initiatives. How these actions take shape, as you can see from the presentation today, they may vary across communities, but the commitment to doing the work, which is not easy, must remain constant. Today's conversation was bold, it was honest, and necessary. My sincere thanks to Angela, Alethea, and Karen for sharing your knowledge, your expertise, and your living experiences with such generosity. And to everyone who joined us this afternoon, on behalf of the 100 Accomplished Black Women, thank you. Your presence, your engagement, and your willingness to reflect are all part of what drives meaningful change forward. I'll leave you with one word, Ubuntu. I am because you are. Thank you.
Look how far you have come.